In the fall of 2013, 5 great leaders and innovators in the field of vascular surgery passed away. Dr. Wiley Barker spent his entire career at UCLA. He was recruited by the well-known surgeon, Dr. William Longmire. He became the chief of both general and vascular surgery. 2 prestigious awards at UCLA are named in his honor: the Wiley Barker Chair in Vascular Surgery and the Barker Teaching Award. He was known for his book, Peripheral Arterial Disease, and was very interested in medical history, cultivating orchids, and horseback riding. In 1965, in partnership with Dr. Jack Cannon, Dr. Barker developed the loop dissector, which could be considered as a pioneering step in the development of endovascular surgery, which he recounted to Dr. Peter Lawrence.
I wanted to make an instrument that would plow ahead, so to speak. It wasn't a very good idea. Jack's was much better. We designed loops. I went home and bought some piano wire, heated and distempered, if you will, about 3 inches of the end, made a loop out of it that was a loop that sort of leaned forward. I flattened that leading edge a little bit, so it was not quite cutting, but it was a little less than blunt. And I used those all my career until Jimmy Yao borrowed them for a display. They disappeared from the display and never been heard from since.
He is survived by his wife of many years, Nancy. Dr. James DeWeese spent his entire career at the University of Rochester focusing on cardiac, arterial, and venous problems. He was also instrumental in developing the accreditation of vascular training programs and the certification program for vascular surgeons.
President Johnson had established an interest in a battle against cancer, heart disease, and stroke. And the program ended up, what they finally did was establish some committees from all specialties. And these committees were to look at the optimal needs or optimal resources needed for the improvement and performance of excellent procedures, operations, and treatment. We decided, and after writing a paper, sent it around to 50 other people interested in doing vascular surgery, and finally felt very strongly that the way to improve vascular surgery was to get people doing vascular surgery who had been trained in it and preferably certified.
He developed the vena cava clip with Dr. Jim Adams. He is survived by his wife of many years, Patricia. Dr. Robert Rutherford is best known for his leadership as editor of the textbook Vascular Surgery in 1977, as well as for developing reporting standards for vascular procedures. In 1989, the 3rd edition of Vascular Surgery was issued as a 2-volume set, reflecting the growth of the specialty. Dr. Rutherford is remembered by his friends and colleagues Dr. Victor Bernhard and Dr. Frank Veith.
Bob, of course, his gentle and thorough knowledge of vascular surgery, and all the way from the historical up to the current technology, was really quite vast, and he was very, very helpful to all of us in our efforts to accomplish this goal.
We would visit with them and go fishing, go bird watching. He was a magnificent photographer of birds, spectacular. I have some of his bird pictures, and of course Bob is a superstar in vascular surgery, both clinically and academically. He's done everything that one could do, in addition to writing this awesome book, which is the Bible of vascular surgery. He was the editor of the JVS. He's editors of seminars in vascular surgery. Does a magnificent job as an editor, and just as an all-around star. and a good guy.
The 8th edition of Vascular Surgery will be published this year. He is survived by his wife of many years, Kay. Dr. David Sumner was an innovator in the area of non-invasive testing. There is an endowed chair of surgery in his name at Southern Illinois University. The American Venous Forum named a meeting after him, the Venous Summit. His book, Hemodynamics for Surgeons, is a must-read for vascular surgeons. His former fellow, Dr. Ashraf Mansour, reflected on his mentor.
Dr. Sumner is one of those very unassuming gentlemen. He's always dressed in a coat and tie. I don't think I've ever seen him not dressed in a coat and tie. Yeah, I remember one I was on call, and it was a late Saturday night. Sunday night we had this emergency case, and I called him, and he was on call, so he came to the hospital, and I was in my scrubs, and he came to the hospital all dressed up in a coat and tie, always the Southern gentleman that he is.
Dr. Sumner did his military service as Director of Research at the Arctic Medical Research Laboratory in Fairbanks, Alaska. Dr. Roger Gregory, who took over for Dr. Sumner, recalls the experience of following this diligent man in such an extreme setting.
It turned out David had a great tour in Alaska. He had used non-invasive techniques to measure cold injury and to prognosticate the diagnosis of cold injury, frostbite, using venous occlusive plethysmography, so-called VOP. Well, I had no idea what VOP was all about, but David had multiple publications, had done a tremendous amount of research. Well, I'd done zero research and had no idea what it was all about. Dave had no problem at all adapting to cold weather. Well, I'd never been in cold weather in my life, and I was horrified. Dave was wonderful at research, and of course I had zero experience with research. But we did have a number of things in common. We were both from North Carolina. We were both interested in vascular surgery, and we were both very ambitious and wanted to move our careers along. When we did meet in Seattle, Dave was a very quiet guy with an extremely charming wife, Marty, and he assured me that Alaska was just going to be no problem. He said everything was just going to be fine, and that I would go up there and have a wonderful time.
Dr. Sumner was also a vivid artist. His work made the cover of the Annals of Vascular Surgery. He is survived by his wife of many years, Marty. Dr. Roy Greenberg was the recipient of the SVS Innovation Award and held over 50 patents. He can be described as a pioneer of the second wave of endovascular surgery for his work on the branched graft and the fenestration technique.
I believe that innovation is much more complex than simply coming up with a good idea. For a technology, a procedure, or a technique to have a transformative effect on a field of medicine, it obviously must involve a good idea. But to make it truly transformative, hard work from teams of people are required. Such concepts have been exemplified by those whose footsteps I follow in receiving this award. Doctors Tom Fogarty, Juan Perotti, and Tim Tudor were all pioneers. Their work and that of the teams of people with which they collaborated has changed the field of vascular surgery forever.
President George W. Bush visited his lab at the Cleveland Clinic in 2007.
Most importantly, I owe great thanks to my family, my wife Alicia and sons Zachary and Lucas, for standing by me in good times and bad, for without them I would not have accomplished most of my goals.
I want to thank Jimmy Yo and Roger Gregory for this history project and for putting together this memorial. And I feel for everyone in the front row, and I knew all of these wonderful people, and we felt that this was the appropriate way to recognize them, and I appreciate everybody being in the room. Must admit, I didn't appreciate how tough it was going to be. 2013 really threw us for a loop in vascular surgery. You know, we're a young specialty, and these were many people that started us off, and Roy was a little younger, but they were the ones that we always expected to see at this meeting. And they persevered to move our field forward, to get us our recognition. and we'll never forget them. We'll just miss not seeing them. Roy Greenberg was one such man and surgeon, and we have a distinguished lectureship in his name that's going to come next. Roy was quite a pioneer. We once went to Cleveland Clinic to learn how to do endografts for the VA, and he was quite a show person. He put an endograph and sort of got a catheter stuck to a renal artery that day and said that wasn't a big deal. I thought it was, but he just smiled, put in a stent, and said, "We move on." He also, I gave him his general surgery boards, and he also walked in the room for me to give him his vascular surgery boards. And in Roy's way, he goes, "You know, you gave me my general surgery boards too, you know," as he sat down. And I looked at him, I said, "Did I pass you?" He had to think a minute, and "I think you did." I said, "Well, good luck today." He, of course, passed with flying colors. Years later, Roy helped me out a lot. My mother was diagnosed with an abdominal aortic aneurysm about 7 years ago, 6.7 centimeter aneurysm. Not quite sure why she had that. She was in Decatur, Illinois, and I was shipping her scan all over. I thank all of you who looked at my mother's aneurysm, and I thank Bruce Perler, who eventually fixed it in an open manner. And Roy was so great looking at that and said she really wasn't a candidate for endovascular repair. And he's the one that first told me, "You know, Julie, no one really wants to take care of your mother." So I made Bruce do it, but that was Roy. So fitting for our speaker today, for the Roy Greenberg Distinguished Lecture, this person was mentored by Roy, and Roy actually has chosen the first three speakers for his lectureship. And he was mentored by Roy during his endovascular fellowship at the Cleveland Clinic. Dr. Gustavo Oderich is professor of surgery at the Mayo Clinic Medical College, where he also serves as director of endovascular therapy and clinical research. He obtained his medical degree at the Universidade Federal de Rio Grande do Sul in Brazil and completed his general surgery residency there. He then traveled to the University of Utah to complete a vascular surgery research fellowship and to the Mayo Clinic for a general surgery residency and a vascular surgery fellowship. He's trained in fenestrated and branch endograft techniques at both the Cleveland Clinic and the University of Melbourne in Australia. And we know him because he's a member of 12 of our societies, and he's a distinguished fellow of the Society for Vascular Surgery. He's associate editor for the Annals of Vascular Surgery and sits on the editorial board of 9 vascular surgery specialty journals, and he's the PI for 12 industry-sponsored trials involving branch technology, and he's the national PI for the T-branch stent graft trial. His special interest is in complex aortic and mesenteric disease. Please join me in welcoming Dr. Gustavo Oderich.
Wow, I thought it was going to be tough, but I think it's going to be even tougher. So, it is a singular privilege and an honor to present you with this year's Roy Greenberg Distinguished Lecture. For me, this was a daunting task. Not only given that I was invited by Roy himself, but it's very difficult to summarize in 20 minutes his major contributions to the modern treatment of aortic disease. These are my disclosures. In preparation for this lecture, I counted with the help, insight, and assistance of numerous friends, mentors, colleagues, artists, and I'm very grateful for that. Thank you. Roy cherished his family and friends above all. He will continue to live on his children, Zachary and Lucas. His presence will be forever felt by his wife, Alicia, his relatives, and his numerous friends within and outside the field of medicine. In the next minutes, I would like to take you into a journey on Dr. Greenberg's most important contributions on modern aortic treatment, and how he influenced the creation and development of clinical and research programs around the world. It is difficult to know where to start. Roy melded clinical practice, research, and innovation into a well-greased machine, with each one of these aspects feeding each other. His brilliant career had broad and extensive background. Early on, he graduated from Cornell with an engineer background, and later obtained his medical degree at University of Cincinnati in 1992. Subsequently, he completed his general surgery training at the University of Rochester. And in those days, he already had a passion for endovascular therapy, and he realized that he needed to master the skills to excel in this specialty. So ahead of most of us, he sought training on interventional radiology in 1988, and additional endovascular training in Sweden under the mentorship of Krasi Ivansev, following the footsteps of another giant, Tim Schutter. He then returned to Rochester to complete his vascular training and joined the Cleveland Clinic staff in 1999. Roy sought training and advice from the best of the best. And as he became close to aortic disease, he became very close to those who were experts in the field. And later on, these mentors would often reach to Roy to help take care of the most difficult patients, or to ask his advice for patient care, research, education, or innovation. As remembered by Dr. Krasi Ivansev in the recent issue of Endovascular Today from February devoted to Roy, I'll always remember Roy as a gentle and compassionate friend who would extend his hand to me whenever I asked him for advice or for his opinion. And his career climbed fast, and in the course of a decade, he has made substantial contributions to advancement of complex endovascular techniques, with numerous landmark publications and over 50 patents. And for that, he received several of the most prestigious innovation awards, including the Society for Vascular Surgery Medal of Innovation in 2012. He clearly had a vision at a very young age. We don't have the sound.
Technologies that would allow us to go into the branches of the arteries. And people laughed at that. But our first case was 2001, and then that's just kind of blossomed since then.
And indeed it blossomed. And as he accumulated new patents and came up with new ideas and devices, it became clear that he needed to test the technology in a clinically safe manner. And this led to the formation of several investigational device exemption protocols listed here, which allowed him and his colleagues at the Cleveland Clinic to have access to technology earlier and accumulate the largest worldwide experience in pretty much every type of complex endovascular repair. And one of these IDEs, the fenestrated and branch IDE, has already enrolled over 1,000 patients, not counting other IDEs such as iliac branch, thoracic branch, arch device, etc. As pointed by David Hartley, he recognized the need for new and inventive concepts that would improve the treatment and the well-being of patients. Roy's research lab would focus, among other things, on the creation of a durable, ideal branch stent graft. Roy's concept would incorporate the features that he felt would mitigate against the risk of late failures, such as a short length, a long overlap, and vector alignment, avoiding kink or angulation. The concept of helical branches certainly incorporate all these features, and as noted on this slide, by the alignment of the branch to the internal iliac artery and the mesenteric arteries, and the exceptionally short length, well-aligned renal fenestrated branches to the renal arteries. And later, in a recent publication by Tara Mastrati and colleagues from the Cleveland Clinic, this approach with fenestrated branches and helical branches would prove to be a durable alternative, with a freedom from branch-related event of 89% at 5 years, a composite of endoleak, fracture, occlusion, separation, or any reintervention. And a remarkably low rate of vessel occlusion of 1.7% for renal arteries and 2.9% for the celiac and superior mesenteric artery at 5 years. But Roy's most important long-lasting legacy was on education and dissemination of endovascular skills around the world. As remembered by Ken Uriel, an excellent surgeon enhances the lives of many patients, one patient at a time, but an excellent teacher improves the lives of countless of patients in an exponential fashion. And by Michael Lawrence Brown, his legacy secure in the hands of those he trained and taught from all over the world, and who in exponential fashion will pass ethics, skills, and passion to those who follow. In the course of a decade, Roy had a direct hand in the training of 133 fellows, including 42 clinical fellows, 70 endovascular fellows, and 22 aortic fellows, not counting several students who also spent time in his lab and who later went to seek a career in medicine or in the medical field. And to illustrate his influence worldwide, note the number of fellows trained by 3 of his prior trainees, including myself, Tim Rash, and Stefan Hollon. As remembered by Tara Mastracci, Roy would often point out to his fellows and colleagues the importance of planning a durable repair that would last for the lifespan of the patient well beyond 5 to 10 years. Some of his classic lines were to strive for parallel-walled aorta, and that given an infinite lifespan, the whole aorta will become aneurysmal. And as he learned from his experience and of others, it became clear that placement of endografts in vulnerable aortic segments would be prone to late failure from progression of aortic disease, migration, and loss of seal. And as you see on the next several slides, as his experience evolved and of his fellows, he oftentimes would plan procedures in more stable aortic segments, oftentimes above the celiac axis, offering a more durable option and also a bailout in the event of late failure. This recommendation is especially important on a younger patient or those with a long life expectancy and a family history of aortic aneurysm. In this recent publication by Brown and colleagues from the Cleveland Clinic, family history of aortic aneurysm was one of the most important predictors of aneurysm disease in nearly every other segment of the aorta, including the root, ascending aorta, thoracic aorta, and suprarenal segments. Other indicators of progression of disease based on his experience and of others include patients who present with multiple segments of the aorta affected by ectasia or small aneurysms, those who already failed a prior open repair or endovascular repair, and patients who have a disease landing zone because of ectasia, calcium, or thrombus-laden aorta. And the Cleveland Clinic experience would become a benchmark for others to compare their results. And over the years, you would note that there was an increment in complexity of repair and extent of aneurysm repair, demonstrated here by the higher number of thoracoabdominal aneurysms over the years and the decreasing number of pararenal aneurysms. And that also reflects Roy's insight and the importance of learning in the lower risk territories such as the aortoiliac arteries and the pararenal aorta. And then having the experience and the courage to advance to the higher risk territories such as the thoracoabdominal aorta and the arch. And their experience would also demonstrate that these repairs can be done safely and that they are effective, with a rate of rupture of 0.6% at 2 years, and a relatively low mortality of 2% for pararenal and type 4 thoracoabdominal aneurysms, and a higher mortality for type 1, 2, and 3 thoracoabdominal aneurysms at 5.5%. This experience will be replicated by several of his trainees. In this paper by Stefan Hollon from Lille and Tim Rash from Malmo. Their experience with the first 50 fenestrated endografts for juxtarenal aortic aneurysms was compared to their late experience. It took approximately 5 years for each center to accumulate the first 50 patients. And as noted on this slide, over time there has been a significant increase in device complexity, which is shown here by the higher number of fenestrations, the very low number of 2-vessel design, 11%, and the increasing number of 4-vessel design, 30%. And despite these increments in complexity, the authors noted a significant decrease in fluoroscopy time, contrast volume, and a similar mortality rate. At the Mayo Clinic, the fenestrated program started a week after I returned from the Cleveland Clinic, a patient that was referred to me by my mentor, Peter Glowiski. To date, we have treated 250 by fenestrated and patients by fenestrated and branch endografts, including 43% with thoracoabdominal aneurysms and 53% with pararenal aneurysms. Similar to the experience of other centers, we also had a significant increase in complexity of aneurysm extent, which is exemplified by the higher number of thoracoabdominal aneurysms over time and the decreasing number of pararenal aneurysms. And not only aneurysm extent, the complexity of device design increased, shown here by the higher number of 4-vessel designs, with nearly every case implanted or planned for this calendar year having a 4-vessel design. And despite these changes, we have not experienced an increase in mortality. In fact, over the last 3 years, we have not had a mortality. For the entire cohort, our average mortality is 2.8%, and that includes a mortality of 1.6% for pararenal aneurysm and 4.8% for thoracoabdominal aneurysms. We also noted similar changes along our learning curve. For example, the number of thoracoabdominal aneurysms significantly increased in the last few years, as did the number of 4-vessel designs. And similar to Stefan and Tim, we also noted a substantial decrease in fluoroscopy time, contrast volume, and a trend towards lower mortality. As you know, we started our experience with device modifications, trying to replicate a nitinol reinforced fenestration by suturing a wire into the fenestration. We always followed the same principles of sizing, design, and implantation that were taught by Dr. Greenberg for manufactured devices. Despite significant improvements in the modifications, we noted that the lack of a nitinol reinforced ring, which is available in the manufactured device, was associated with several instances of component separations and type 3 endoleak, as demonstrated here. This led to other more creative modifications, such as the use of a mini-cuff reinforced fenestration intended to be breached with a balloon expandable stent, or a directional branch for thoracoabdominal aneurysms. But there were many drawbacks of using physician-modified endovascular grafts. To name a few, the lack of a nitinol ring, issues of quality control, such as potential risk of contamination or violating device integrity, the added cost, regulatory issues with the FDA, the time spent with modifications, the limited reimbursement, and most importantly, the questionable long-term durability. And as such, we moved away from modified stent grafts and embarked on using totally manufactured devices. And the last modified stent graft was done October of last year. This was possible with the creation of a robust aortic research program that currently includes 14 ongoing clinical trials, most evaluating branch devices or complex anatomy. 2 of these trials are investigational device exemption protocols. These protocols are prospective, non-randomized studies that include patients with aortoiliac, pararenal, and thoracoabdominal aneurysms and chronic dissections. We look at the quality of life questionnaires, imaging, and clinical outcomes. This data is gathered by a research coordinator, and there is an independent monitoring adjudicating events. We intend to also open an open surgical arm to be followed prospectively, allowing comparison of results between open and endovascular surgery. The endovascular group is treated by means of fenestrations and branches with one of two options: an off-the-shelf design with multi-branches designed and pioneered by Dr. Tim Schutter, or a custom-made device with any combination of fenestrations and branches. Sizing and planning is critical for this procedure. Other important contribution of Dr. Greenberg was to help develop softwares that would facilitate the interface between digital imaging and planning fenestrated and branch repairs. These softwares would allow measurements of lengths and axial location of vessels that would translate into an engineering plan and a device, such as this one with 2 branches and 2 fenestrations. The procedure is done using bilateral femoral approach, oftentimes percutaneously. We still use precatheterization, but now rely on onlay CT. After the vessels are located, the branch component is introduced. We oftentimes have preloaded catheters which allow a snare to be wired from the arm and immediate access into either the fenestration or the branch from above. In this example, a celiac branch is catheterized, and using onlay CT, the wire is advanced to the celiac axis. And once we establish access in the celiac and the SMA, the device is deployed, the renal arteries are catheterized, and alignment stents are deployed into the renal arteries. At this point, we have the option of finishing the repair in the bottom part with a bifurcated device, or completing the repair from above by stenting the SMA and the celiac axis. We use MEP monitoring to decide which one we do first, based on changes in lower extremity function. Since the implementation of these trials, 89 patients have been included and 66 underwent implantation, with 23 patients pending device implantation. Of the patients that already had device implantation, 23% had thoracoabdominal and 83% had pararenal aneurysms. You see the majority of patients had either a 3 or a 4-vessel design. The fluoroscopy time and the contrast volume are similar to what was already described. Our average endovascular operating time is 160 minutes, and the major adverse event rate in this cohort was 23%, with no mortality, conversion, or rupture. As expected, our follow-up is short, with a mean of only 9 months. Of the 206 vessels targeted by stents, we had 2 occlusions and 4 stenoses. There were no type 1 endoleaks. 20% of the patients had a type 2 endoleak, and 2 patients with iliac branch devices developed a type 3 endoleak. Despite the short follow-up, 74% of the aneurysms sac have shrinked, and 17% of the patients required a reintervention. So in summary, Dr. Greenberg's contributions are many. He accumulated the largest worldwide experience in pretty much every type of advanced endovascular repair. He has provided many insightful talks and multiple landmark publications. He contributed with over 50 patents, including helical branches, imaging processing for planning and intraoperative guidance. And according to Dr. Greenberg himself, his most important patent is yet to come, and it is a supraannular aortic valve that would bridge the aortic valve to an arch device. And most importantly, his long-lasting legacy is the development and dissemination of endovascular skills, which will be perpetuated in an exponential fashion by his trainees.
We've taken an area where there's been 10 to 20% mortality from procedures and brought the risk of death down to below 2% or 1% in some cases. We'll never be perfect with how we treat patients, but we have to be as close as possible.
Thank you very much.